So welcome to week 6. I'm still impressed that we are halfway through. I'm going to warn you, it's going to start getting pretty rough on you. So please listen to what I have to say. It will hopefully will help you. Now, you're going to see that there's an assignment, calculate with confidence. And it is your pediatric section of that book. It is pages 699 to 709. It's 61 questions. Now, you have all the answers in your book. There is a handout, that you could put all the answers on, or I've had students do it written on paper, and there's multiple uploads available for you on that section, so you can hand it up that way. Another thing that's coming up, week 8, you have a project due. Now, this is a 3-part project, and you're also going to have community coming up. So there's a lot of things. So if you can start working on that project, it's going to help you. Remember, it is a pediatric diagnosis that you are going to do a teaching of that to either the child or to parents. Even some, I've done it also to nurses. If it was a different diagnosis, different syndrome I've never heard. I've actually, when I was on ground, used to have my students present it to the nurses at the facility that we were working at, and they absolutely loved it. So it is a section where you describe what the project is, a 250-word APA paper. The second part is an assessment form, which is attached to your module to it. Please do not write normal. Our heart sounds aren't normal. Tell me what they sound like. Don't tell me breath sounds. Normal. Tell me what, if you're saying it's asthma, tell me what breath sounds sound like when you have an asthma attack, okay? There's wheezing and retracting and grunting, whatever age, whatever you're looking at, okay? And then the third part, you could do a brochure, you can do like a picture board, or most students decide to do a PowerPoint. Now, I don't need a 30, slide PowerPoint. Usually students do maybe 5, 6 slides, and you're gonna do a teaching. It could be things like diabetes, how to give an insulin injection, how to monitor blood sugars, what's normal things for the child and the parent to know. So teaching, it could be teaching that nurse, if you're going to do it to nurses, what is the syndrome? What are things you need to look for that can help you take care of that child? And if you're doing it to the kid, maybe it's how to give an aerosol, with a spacer, and give me step-by-step directions. It doesn't have to be absolutely crazy. It's 5 slides can do it. Just remember to put references. And because it's a 3-section type of thing, at least 2 references I would prefer in them, okay? Now, the one thing I do for you is when I get that project and I think there's things you can change, I will give you the opportunity, if you want, to increase your grade, to change. Maybe it was your references weren't written right, or you forgot to put your references, or you could have done something in the teaching that I thought would be better. I will let you just go ahead and resubmit it and get a higher grade. So, and I will let you do that, up to 1 week after the project is due, okay? So I'm trying to give you that opportunity to get your best grade possible. Now, it is 6% of your subjective grade, so it is a big portion. Make sure that you send me, what diagnosis do you want to do? Could it be a syndrome? Could it be Pierre-Robin? Could it be tetralogy of Fallot? Could it be Down syndrome, autism, ADHD, autism, urinary tract infections, asthma? I mean, there's so many kids' diagnoses that you can look at. Open the book, put your finger down. You can find some really interesting things. I highly suggest choose something that's near and dear to your heart. Maybe your child, maybe you, maybe the neighbor, maybe your best friend's kid had something and you want to know more about it. And this will give it to you, instead of just doing a project that's non-interesting, something that you're interested in understanding more about. Okay, These are virtual children. Make an age and make your assessment appropriate to that age, okay? So just send me what you want to do and I will give you the okays for that. Quiz number 4 is due by Sunday. You should be able to do that fine by after this class today. The 2 case studies inadvertently closed early. I'm opening them up, the CHF and the cystic fibrosis, coronary heart disease, and CFF will be open till Sunday. So I'll be opening them. So if you got a 0 there, don't freak out. I entered them wrong. We had the wrong dates written down. So you will have that there. Next week is your second exam. We have started reviews, which will start on Wednesday. I'm doing a Friday afternoon one, something different, okay? And there is a Saturday morning 10 a.m. review also. You, of course, will get all the recordings and I'll post them to the review recordings area in the announcements. I have already sent you the PowerPoint on that. So you can, whatever you do, whether you keep it online or you print it, whatever it is there. I had that up on Sunday for you. Any questions? So this week is an interesting week. We're going to go over hematologic, immunologic, and the child with cancer, some things about that. And then we have a Kahoots to follow. Any questions so far? Okay. Tina's asked permission to stay off, but Dominique, Ulysses, and I believe it's Michelle, Chanel, please put your cameras on for me. Ulysses, there you are. And Chanel, beautiful, you're in the car, are you driving? Okay, as long as you're not driving, anybody who's driving, I do not want their cameras on. If you want to listen, it's like listening to a radio, but not looking at, the PowerPoint. You will have that recording by tomorrow that you can look at. Thank you, everybody. All right, let's get going with this week's. Remember, any questions, stop me as we go, and I can help you with it. So start out, hematologic, immunologic dysfunction. So first of all, how do we know if there's a hematologic or immunologic dysfunction? Well, the first thing is not a complete blood count because that's real good information, but history and physical, what is going on? I think the easiest thing to figure out is if we have these complaints that this child has lack of energy, and through that history, or bruising, or getting lots of infections, you'll see through that. Then, all right, let's do a complete blood count. Now, what are we looking for in that complete blood count, that CBC? Well, the white count will show us if there's an active bacterial infection, okay? It also is going to look at your blood counts, your hemoglobin hematocrit, because lack of energy could be iron deficient anemia, and that could be a low hemoglobin hematocrit. And then there are some bleeding coagulopathies would have to do with platelets. So those things would be something that we look at. We know iron deficient anemia is usually because children are growing, they're very picky in what they eat, and they have, some of them don't like milk, they don't like green leafy vegetables, all of these great places that you can get iron, they don't like to eat them. So you're going to see that there's poor iron, just in the diet alone. Now, if we're having, I said, increased infections or bleeding, besides the CBC, we're probably going to be doing maybe looking at blood coagulopathies, your PT, PTTs, and other bleeding programs that we can do there. So red blood cells. Well, first of all, what do red blood cells do? They carry oxygen and they carry iron. So if we don't have enough red blood cells, we're not going to have enough oxygen. We're going to tire easily, right? And if we don't have iron, again, the most common complaint is I don't have any energy at all. So This is iron deficient anemia is the most common of all, but there's other reasons why we have anemias, and we're going to go into them. So we don't have red blood cells, hemoglobin, it's the same thing. It's iron and oxygen don't have enough. They say in children, we allow actually lower hemoglobin hematocrits than we do in adults. Because it does take a little bit of time for children to catch up making their own cells, but they'll say hemoglobin less than 10 is where we're going to start doing the treatments. Now, in your book, this is a picture that's there. It talks about types of anemia. So we have decreased red blood cell production. There's some reasons for that, or an increased red blood cell loss. We have some of those, and then increased red blood cell destruction. So there's 3 different types of anemias. So decreased red blood cell production, this is where we see that nutritional could be from iron deficient anemia. You don't have enough blood cells, so there's not an iron. Therefore, you're going to have that chronically being tired. B12 is the intrinsic factor, right? So that could be part of the nutritional anemia. And then anybody who has chronic blood loss, and it could be to many different things, but let's say hemophilia, it's a chronic blood loss, right? Now, it can be due to a bone marrow failure. Now, aplastic anemia is a type of anemia where all the cells in the body do not produce. You don't have enough red blood cells, you don't have enough platelets, and these children are going to be needing something to help replace all of those cells, whether it is blood transfusions. And then, of course, we can go into bone marrow failure as leukemias. You know, we have the ALL, leukocytic leukemia, and then we have AML, myelocytic leukemia. ALL is the most common of all of the blood cancers, but it also really eats up all of your cells. So you'll have low hemoglobin hematocrit, low platelets, and then you're going to have some bleeding going on in there. So increased red blood cell loss. Now, sometimes children go along and we don't know they have any sort of bleeding problems. And then they start with nosebleeds, epistaxis. And then, you know, like they have one arbitrarily, there's nothing to do with it. But what if we're having chronic nosebleeds, epistaxis? So you have 3 within 2 months. Well, then it's when we need to look at what's going on in the blood that's causing that. So we will do blood tests. We'll be looking at a CBC. We want to look at platelets because not enough platelets. This patient should be on some sort of bleeding precautions because they're going to bleed easily. Or is it one of those PTTs, or maybe it's to the point of, you know, hemophilia that, you know, has now come into fruition. And we know hemophilia, this is where a factor in the body is just not there. So you need all of the, you know, I's dotted, T's crossed, and in hemophilia, there's T's and I's not crossed, and therefore there is going to be increased evidence of bleeding. Now, ITP is idiopathic thrombocytopenic purpura, which is, if you think of the P, think platelets. So it is decreased platelets. And no platelets, you're going to bleed. And then DIC is something called disseminated intravascular coagulopathy. This is when you have a child or an adult in the ICU, overwhelming sepsis, and now the body doesn't know what to do with its blood. And it's just a really difficult thing to, number one, be a nurse and treat, because it's constantly given blood transfusions and all different platelets and FFP. And it's very difficult to treat, but it can be. Now, increased red blood cell destruction, think of thalassemia and think of sickle cell. You know, sickle cell, we have sickled cells, you know, but they die quickly. So if they're, I'm telling you again, they're dying quickly. Sickle cell children have very low hemoglobin hematocrits, okay? And then thalassemia. Thalassemia is the cells just burst constantly, very short lives, and they spew iron into the blood system and they become intoxicated with iron. And we're going to go into that too. And then, of course, we have immunologic or due to infection, which can also occur. So anemia. Well, when you are anemic, you have less blood cells in your blood vessels, okay? So when you listen to a heart go with the blood going through, you're going to hear swishing and you're going to hear murmurs because it's not all packed with cells. It's swishing in there, those cells, okay? So it's going to be diluted, hemodiluted. Can you imagine having a child, an adult, come in, you know, let's say to the emergency room, and they're low on blood for whatever reason, and their blood pressure's low, so we give fluid. What have we done? We've more than hemodiluted that blood. So we might have started out with a hemoglobin hematocrit of 6 and 18, but by the time we give extra fluid to give volume to the circulatory system, you might be down to 4 and 12 as your hemoglobin hematocrit. So think of that as you are, you know, giving these boluses of fluid to patients who have lower hemoglobin hematocrits, because, you know, it is that turbulence. And if we allow the anemia to stay there, we're going to see cardiac failure. Why? Well, the heart's trying to get all of this, you know, oxygen and iron all over the body, and there's not enough. So it keeps trying and trying and trying. And finally it says, you know, I give up, I'm tired here. And that's when the failure occurs. Of course, no oxygen, you're going to see cyanosis, and no oxygen is part of nutrition, and no nutrition, you're going to see a child who's going to be smaller, growth retardation. So how do we go through this? Well, number one, you need to diagnose it. Like I said earlier, history, physical, do a CBC, just simple. Find out what's going on. Not just treat the symptoms. We could give blood to everybody. I mean, that treats the anemia, but why did it happen? So finding out that underlying cause. If it is something nutritional, iron, or the intrinsic factor, well, let's replace those factors so that we can, you know, figure out and treat the anemia. As I said, we'll give IV fluids to replace that volume because the heart needs a certain amount of volume in the circulatory system. And they say oxygen. Now, the one thing I tend to warn you about is if we don't have cells to carry oxygen, is oxygen therapy going to be, is it going to work? Well, maybe, maybe not, right? But they feel give it a try. The most beneficial thing is rest. You know, if you're not burning any energy, you're saving your oxygen, and then letting the heart and the body get what it needs, or else you're going to burn out the oxygen. So another thing to look at when we're looking at anemia, we need to look at how old's the child and what's the racial ethnic background. And we know sickle cell's African American, right? Then we're going to go into a thalassemia and we're going to see Mediterranean people. So understanding ethnic background is important in this. That good old history. And then we're going to do a stool for occult blood. And the reason is we have to rule out acute bleeding in the GI tract. So just don't assume that it is iron deficient anemia or something else. Rule out that it's not active bleeding. So children hate needles, they hate pinches, so you need to prepare them. You know, today, getting a child to sit and to get lab works can be difficult, but how am I going to do that? Well, number one, I'm going to be honest. I'm going to talk to them, tell them what they need. I might even have them pick which arm, which vein do they want me to get and put the needle in to draw the blood. And most likely, I'm going to let that child sit on the parent's lap. Because when they're sitting on the parent's lap, this is my dissertation for my PhD, it's Huggies, help us give great injections efficiently and safely. Because a child who's held by a parent before the procedure, whatever it is, whether it's labs or getting a shot, doesn't matter, they're going to be less fearful and less stressed before, during, and after because they're in mommy's arms already, okay? And then, of course, today we have all these numbing creams and distractions that we can use to help them, so they're not going to be just focused in on that needle. And in the end, hopefully this child's not going to be afraid of getting it again. And then, of course, with anemia, prevent complications. And this has a lot to do with not having enough nutrition or enough oxygen. So as I said, iron deficient anemia, probably the most common of all of the anemias out there. And it's because they're not getting enough iron. Now, infants at birth, if they're not on breast milk, are going to be given iron fortified formulas. At 6 months, we give cereals, but it's iron fortified cereals because the infants need that iron in the body. Adolescents, we know, we've talked about it, they don't eat well. They eat on the run. They get a snack bar, bottle of water, and one for the day, and maybe an apple if they're lucky. So they're not getting enough iron, and that usually is why they're going to see iron deficient anemia at this age. Years ago, we had these children and we just gave them whole milk earlier than 1 year old, and that doesn't have any iron in it. So that's what Milk Baby is talking about. Prognosis for these children is great because all we need to do is either change the diet or we need to give iron supplementation. Sickle cell anemia, we know this has to do with African Americans. We know that if both parents have just the trait, each of their child has a 25% chance of having that disease. So what happens in sickle cell anemia? Well, what happens is, and it's usually due to things like an infection. I mean, if you have a child who's now been diagnosed with sickle cell anemia, one of the teachings that you're going to teach those parents and the child is if they have a fever over 100.5, they need to tell their physician because they need to be placed on antibiotics immediately. These are immunosuppressed children, okay? So in sickle cell, the shapes of the red blood cells are in a sickle and they die quickly. Therefore, hemoglobin hematocrits are really low. Not uncommon to get a child into the emergency room with a sickle cell crisis with hemoglobin hematocrit 618, 7 and 21. Not uncommon at all. And one of the first things we do, besides giving fluids, be giving pain control, is giving them blood. Again, these children, if your hemoglobin hematocrits are low, you're not getting oxygen, and nutrition, et cetera. So it's that local hypoxia and just tiredness, and your body needs oxygen. So sickle cell crisis, why do we get them? Well, sometimes it's emotional, it's stress. That's the big one in any of these immunosuppressed things. Let's say that you have to do a lot more, with your body and you're pushing it hard and increasing that need for oxygen, that can cause it also. Infection, fever, and then dehydration is a big one with this one. And then, of course, the hypoxemia, which again is due to low hemoglobin hematocrits. So how do we take care? Let's go down to how do we take care of this? Well, the first thing we do with a child with a sickle cell attack is we've got these sickles that came to a bifurcation in a vessel. It's one little sickle's come and blocked it off, and then it backs up behind it. So blood can't go down. So it swells and causes a lot of pain. So how can we get that blood through that bifurcation in the vessel? First of all, number one thing you do, hydrate that child, okay? When you hydrate, give a bolus of fluid, you're going to dilate the vessels, therefore allowing the blood to go through. Immediately with the bolus, we're going to be given those pain meds also. And heat dilates the vessels too. So it's like boom, 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 all at once. Dilate that vessel, let those cells go through, and it helps eliminate that pain and that swelling the child is having. I mean, our goal absolutely is to minimize and stop as many of these sickle cell crises as we can. So we need these children to be rested, not to overdo themselves, and hydrate. If they're outside, they can have their Gatorade or one of those things with electrolyte replacements really constantly, because they're sweating out their electrolytes. They do tend to lose, a lot of those electrolytes, as I said, with the sweating. So again, replace them. And then something for pain. I mean, I know one of the most common things that sickle cell children in the facility where I just came from is they would send these children home with Tylenol number 3s. In case that they're having the mild pain, there was something they could start right at home. Because, right, if you don't treat it right away, you can never catch up. And this is true with sickle cell. Now, as I said, these children will be getting blood replacement and transfusions as they need them, depending on how low their hemoglobin hematocrit goes. And then, of course, patient condition. What do they look like? Do they look like they need it? And then, as I said, antibiotics. Most of these crises are due to infection because they are so immunosuppressed. Now, there is no cure, but they're thinking maybe some bone marrow transplantations can help. Our goal is to prevent these crises and to try to keep down the amount of bacterial infections. We know that those bacterial infections in this immunosuppressed child is the leading cause of death with sickle cell, because they don't get into the physician quick enough, and then the infection just overwhelms their bodies and they can't fight it. Sickle cell children can grow up to be adults and do well, but they need constant monitoring and due diligence and making sure that if they see something going on, seek early intervention. Many children from about 2 months to about 5 years are given a prophylactic 1 penicillin pill a day. And this is prophylactic to try to help the body. Children and parents, as the children get older, and parents need to know that some of the biggest issues with sickle cell is the neurological things that can happen, which is stroke, because you can have a sickle cell in your brain. And what might that come out as? It might just be a headache, or it might be a pain in that eye. These are things that could be an impending stroke. So it needs immediate treatment. Respiratory problem, you can sickle in your lungs too, and it can almost look like a pulmonary embolus. It hurts so bad. I mean, we want all children to treat them normal, let them be kids like kids should be, and we really want to help prevent that sickling. So keep them healthy, keep them infection-free, keep them hydrated with their electrolytes. So I really have gone over these sort of things here. The one thing I didn't is monitoring of the retic counts is called, to evaluate bone marrow functions. Because when an infant is born, they don't make their own red blood cells. They don't. It takes about 3 to 6 months for them to start making their own. That's why I told you about 6 months to have an infant with a hemoglobin hematocrit of 10 and 30. It's not uncommon because they're not making cells yet. So if we start monitoring the retic count, we can see how quickly is that body working for itself. And as I said, blood transfusions are there. It's just to make sure that get oxygen to the body. Thalassemia. So we had African Americans, now thalassemia, people, descendants near the Mediterranean Sea. And what it is, if you look at these pictures, they're rectangular cells, and they tend to just burst. They are very short life. I mean, your body's producing cells. It's not a problem at all, but they burst quickly. Well, what's inside those red blood cells? We have iron in there, right? So when we're looking at thalassemia, there's no way to give blood cells to these children that are healthy unless we give blood transfusions, because their own body, their own spleen, their own bone marrow is producing these rectangular cell-like things, structures, and they're bursting and they're dying quickly, 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 and they're spewing iron into the body of these children. So what's the problem with this, short life and the spewing of iron? You can become iron toxic with just the amount of iron inside the cells. So we've talked about in pharmacology about iron chelating drugs. And this is one of the reasons why we would use it. It takes and combines with the iron, and then you excrete it through the kidney. So it can work really well. Now, what is difficult about thalassemia is initially these infants will not show thalassemia. Their blood cells, remember, they come in from mom. If they don't have thalassemia, you're going to have normal red blood cells, but then about 6 weeks of age, it starts to change. And then what you'll see is that failure to thrive, and then you see an extremely anemic child, and then you start looking at the cells, and you're going to start saying, okay, what's going on? Checking those iron levels and checking those hemoglobin hematocrits. And again, thalassemia, the only treatment is to give blood transfusion. Try to replace and give some good cells. Now, people with thalassemia, as long as they're diligent and getting their blood transfusions, they can live, a longer life. But what happens? You have thalassemia, cells are bursting, you're anemic all the time. Remember, anemia can lead to heart failure, right? So it's working hard and you're always replacing. It's like a lot of cells, not enough. A lot of cells, not enough. So the heart is confused, and usually you go into heart disease. And it also causes a multi-system failure. You don't have oxygen, and you've got too much iron in your body too. So that's that multi-organ failure. Many times, to get rid of these cells, they will do a splenectomy. But again, these are immunosuppressed children that become immunosuppressed adults, and they can get extremely septic after surgeries. Again, maybe the bone marrow transplantation is a cure, but it's still not, definitive yet. So what do these children and becoming adults, what they need to do? Well, they need to be compliant with getting their blood transfusions and monitoring and keeping on top of their iron levels. So chelation therapy, whether it's chelation therapy through medications or chelation therapy during something called apheresis. It's similar looking to like a dialysis machine, but it's a little different. All it does is removes the iron out of the body. It's pretty neat, this apheresis. You can only pick components that you want gone. Now, again, these children are constantly getting blood, constantly at a doctor's office or an outpatient center, getting transfusions, getting lab works drawn. So, these children are going to be anxious. So from the beginning, we really need to be, very patient with them so that this whole thing is not this big, oh, I didn't get my blood into, and make it fun. Oh, I'm going to go see my nurse, Nancy. I hope she's on today. That's what you want. You don't want them to be afraid. And then, of course, parents need to be told that what they're doing and helping their children and adjusting to it, praise them for what they're doing. And these children are getting blood transfusions, some every week, some every month. It all depends on how many cells are bursting. So again, blood transfusion reactions. You get a blood transfusion reaction and you're giving that blood, the first thing you're going to do, turn off the blood, right? So aplastic anemia. Now, this is a suppression of all formed elements of blood. So you're anemic, so hemoglobin hematocrit are down, therefore that's the anemia. Leukopenia, your white counts are going to be low. Again, immunosuppression. And then thrombocytopenia, remember P equals platelets, low platelets. So you are anemic, you have an elevated white count, you have no cells to fight infection in there, and then you have no platelets, so you're going to be bleeding too. So it's a profound depression of RBCs. You sometimes with the hypoplastic, you might see white cells, but usually when we talk aplastic, it's RBCs, white blood cells, and your platelets. So we treat aplastic anemia just like we treat leukemia, which is, what are we going to do? We're going to be giving those immunosuppressive therapy and bone marrow transplant to this one. So this is, again, one of those conditions that's going to be a chronic follow-up. So hemostasis, this is bleeding. So defects in hemostasis equals bleeding going on somewhere. So let's look at those. Well, when you think of bleeding, number one, you think of hemophilia, right? Hemophilia is an inherited condition. It is mom, X-linked recessive, all right? The thing with hemophilia is there's a couple different types. So if you think of blood clotting in your blood, it's not just one thing that clots blood, it's several things that help it work. So we have different things called factor 8, factor 9, von Willebrand's, and these are factors that when you're bleeding, all of a sudden you clot off and you stop bleeding. Those are factors that stop it. So the normal one that we think of is factor 8. It's the classic one. But then there's factor 9. It's a Christmas disease. It's just a different factor. They still do the same thing. One's not better than the other. They're both hemophilias. And then there's von Willebrand disease. And it was von Willebrand was the scientist who found it. And it's that factor and factor 8. So what do we see? Now, remember I was talking about having those epistaxis and nosebleeds all the time, and then you start looking for things. Well, it could be just the platelets on the problem, but it could be something else happening here. So we're looking for those overt prolonged bleeding. You know, you start seeing, you know, you get it fall down, you scrape your knee, and you keep bleeding, bleeding, bleeding. You cut your finger on a knife, and it keeps bleeding, bleeding. That's not right. Or you're going to see these big bruisings, this ecchymosis, these ecchymotic areas, or you fall and you're going to see your knee full of blood. And this is part of that, this is something to do with bleeding. Let's go and let's look at laboratories. Remember, it is X-linked recessive, all right? So what do you see in laboratory findings? Well, is it factor 8? Is it factor 9? One of those. And then you're going to see, when you think of bleeding, think of heparin, okay? Which is the PTT, right? Heparin, we evaluate it by monitoring the PTT, the APTT in the laboratories. So those are things you would see. Now, the platelet count that was going to be normal. And then these other levels are also has to do with bleeding things, parathyroid and fibrinogen. But to know hemophilia, it is the factor and a prolonged PTT. The rest is normal. So how do we treat hemophilia? Well, we need to replace the factor. Now, I'll give you a scenario. You get a child, and this happened to me where I had this boy. He was, I don't know, 8 or 9. He was not old, but not too young. And he had fallen, and his knee was really swollen and ecchymotic, you know, hemarthrosis. And the dad brought him in because couldn't get a hold of his hematologist and wanted to know, hey, do I need to give the factor or not? And actually, the physician told him, yes, you can give the factor. Now, he had brought it from home. I watched this father and this son sit there. The son chose what vein that he wanted him to use. The father mixed it up, put it in the syringe, the tubing, and slowly pushed it in while the son held that little butterfly in place. And I was like, this was the most beautiful thing. And that day I had an orientee with me who got to watch this. And I said, you'll never see anything like this ever again. It was so well done. And the father really understood about giving it. And the son was very cooperative because he was made a part of the treatment, not just give me your arm, stick a needle in. He was part of holding it and, choosing the vessel. Now, sometimes we don't need to give IV stuff. We can just give some nasal spray, and these are milder hemophilias, okay? And then there's also aminocaproic acid, but mostly you're going to see those replacing those clotting factors. And remember, when we have a hemophilia, knee, fall down, something's bleeding, what are we going to do? Well, think of rice. You're going to raise it, you're going to rest, you're going to ice it, you're going to contain it with an ACE bandage and elevate it, right? because, and ice helps it constrict, so it stops bleeding. The containment keeps it in its place, and you elevate it, and it's going to hopefully slow down the bleeding into the joints. Because if we don't protect those joints as they get older, they're going to be destroyed and going to end up in wheelchairs, which we don't want to do. They don't need to be. So as I said, hemophiliacs, just like any other condition, can live pretty normal, but this child's not going to be in football. This child's going to maybe go swimming, maybe bowling, maybe tennis, something else. They're not going to be in something where there's a lot of contact. So as I said, control those symptoms, protect those joints, and then hopefully, they're getting close to some gene therapy so that factor can come in and we can help cure some hemophilia. So our goal is to prevent that bleeding. As a nurse, you're going to have a safe environment. And remember, they bleed through their gums. So be very careful, soft toothbrushes for these children. So recognize control bleeding with rice, like I just said, prevent those crippling effects. And then remember, these children will be getting home care, teaching these parents how to give this therapy. And again, genetic counseling, so that these parents can understand their chances of another child with hemophilia if they want it. Now, immune thrombocytopenia or idiopathic thrombocytopenia purpura. Thrombocytopenia, think of P again, this is platelets. Platelet counts are very low. Now, I have seen children, this is that nosebleed that comes in usually, okay? And they've been bleeding, and then we start looking. And then they start showing me their legs with this purplish, petechial looking rash, like little dots, and they're little purple in them. And you're like, okay, and what do we do? Well, number one, have you been sick lately? It usually follows an upper respiratory infection. This is a condition that could be an acute condition, or it can become lifelong or a chronic condition. But usually what they do with these is they'll say, have you had an upper respiratory infection? And we're going to be doing a simple old CBC. And we're going to see the platelet counts low. And we treat this with IV immunoglobulin and anti-D antibodies. Now, the thing with thrombocytopenia or any bleeding condition, you must be careful with putting them in a very protective environment so that they're not going to bleed. So avoid venipunctures, avoid IM injections, look for bleeding, gums, urine, stool, monitor those blood counts, that platelet count, where is it? I mean, platelet count should be minimum over 100,000. Many of these children, you'll see at 10 and 15,000, their platelet counts. And then sometimes what they do to help this is corticosteroids. Now, one of the things about thrombocytopenia that I wanted to mention is usually it takes a while to cure it, maybe up to about a year. But with diligence, it can be cured. And if after a year, if it's still there, this child's going to be living with monitoring his platelet counts. As I said, DIC has to do with shock, sepsis, and it literally has too much thrombin is out there, so clotting is coming on. So we treat it with heparin, and it's just, why is it happening? Is it sepsis? You're going to treat it, and we'll give IV heparin, and we'll give stuff also for the bleeding coagulopathy that's going on. Did you ever hear of an exchange transfusion with your newborns due to hyperbilirubinemia? All it is pulling out and pushing in blood. And sometimes we can, on the smaller children, do this exchange transfusion, and we can help get rid of the DIC, of course, with the other treatment. As I said, epistaxis is one of those things that can alert the healthcare professional there's something going on with bleeding coagulopathy. So what do? Number one, have the child get calm. Children see blood and they just freak out, and I'm dying and it's pouring, and you're like, just sit down. Take your fingers, put it under nasal pressure, 10 minutes, and you want this child to sit up and lean forward. So the blood comes out, they don't swallow it and vomit it, okay? And if it doesn't stop after 10 minutes, go to the emergency room. Now, one of the immune conditions is HIV/AIDS, and you're thinking, well, pediatrics. Well, remember, children are born with HIV, right? It's from the parents. So what they're doing today is they're doing this heart therapy, and it's highly active antiretroviral therapy. And what they do is they start, perinatal, about 22 weeks of gestation, and they continue that up, and they do that after birth. Now, when the infant is born, they're going to be put on these antiviral therapy immediately. And why? Well, we want to boost that that newborn's immune system. Now, just because an infant is born with HIV doesn't mean they have HIV. They can convert. I have seen triplets born where one of them had HIV and continued with HIV, and the other two converted and they were not HIV. So it's because we gave that antiviral therapy and the antiretroviral therapy to the mother because we wanted to improve that newborn's immune functions. So one of the things with, as I said, the immune system and the infants is our thing. Now, there's two different opportunistic infections we have. Yeast, which they get, but I think the worst of all is the PCP pneumonia, the pneumocystic cardiac pneumonia. And this is respiratory. And the reason we would know is, how do you know if a child has a respiratory problem? Well, you're going to breathe more. You're going to see them retraction, requiring more oxygen. O2 sats are dropping. So that's how we would be alerted to those sort of things. So our goal is to, number one, promote immune function for those infants that have been exposed. We want to educate, especially adolescents, telling adolescents, proper safe sex practices, and then of course, when we have children, newborns that are born HIV, again, keeping it confidential. All the parents in the room don't need that this child's mother was HIV. So how do we manage hematologic immunologic disorders? Well, blood transfusions, number one, right? We have packed blood cells and we have whole blood. Whole blood is when you need volume, blood loss, gunshot wound, you want whole blood, you want volume and packed cell and the red blood cells. Packed red blood cells are usually given to those that cannot tolerate all the volume. Usually packed cells are half the volume of whole blood. So you set up the blood, make sure you do it according to policy in your hospital. It takes 2 RNs, 2 nurses to check the blood, making sure that it's correct, hanging it up, vitals before, vitals 15 after, and then every hour you're doing vital signs. And again, any reaction, first thing you do, turn off the blood, okay? And I already mentioned this apheresis, and there's many things we can do with it. We can do it with the iron chelation therapy. We can get rid of iron. We also can, take platelets out. We can do a lot of things that work really well. So if both parents have the sickle cell trait, what is the chance that each of their children have sickle cell anemia?
25%.
Yes, it is. Okay, some neoplastic disorders. The most common of all types of childhood cancers is blood, or blood forming organs. And number one is ALL, the acute lymphocytic leukemia, okay? So leukemia, more common in boys than girls, greater than 1. And they're usually 2 to 5 years old. And today, because of the advances, cure rates are amazing. They do well, but it is a long-term care. it's over a year or more that they have to, go through getting chemo and blood and coming in because they have an infection and need antibiotics, et cetera, et cetera. But leukemias. Yes, Jasmine, did you have a question?
I just got done with my peds rotation, and I had a patient who was 3 years old, and he had leukemia. He had AML since he was 18 months old, and he was actually in remission. He started remission in December, but then had to come back because he came back into
AML is hard. AML is the harder one to cure.
Yeah.
ALL is easier. AML is the harder one. Did he go for a bone marrow transplant yet?
So he's been doing the lumbar punctures here recently too, I guess. So he did the bone marrow transplant, and his parents were talking about it my first, not like this past week, but the week before that. They were like, we had saved the cord blood because we thought we were going to be able to use the cord blood in the future for something like this. But she was like, we did have to go through the bone marrow transplant. I mean, is that what the bone marrow transplant, is that what we were just saying? Yes. But it hadn't really worked. So what I was going to say is they're going through a trial right now for CAR-T. And so they've been doing that since we were talking about sickle cell too. They do that with sickle cell, and it's been curing the patients the CAR-T has. Well, it's been lowering their sickling of their cells for up to maybe 5 years with them doing the CAR-T, but they're doing the CAR-T, I can't think of the word I'm looking for, they're doing the trial for the CAR-T on them because they just approved it for kids his age.
Wow.
So
they're trying so many things, trying so hard. And, you get these pediatric hospitals that are teaching centers, and they have research going on, and, they've made great advances, but, you just mentioned, the leukemia that's the most difficult to cure, the AML. And sometimes it takes 2 bone marrow transplants. I mean, seriously, it's a difficult one. So again, you could see how much you need to be there for the parents and for that child. Because, in bone marrow transplants, they are put in these rooms alone because they strip their whole immune system to 0 in order to get that bone marrow in for it to take. So these children are scared. They really are, and my next door neighbor came up with ALL at age, she was older, 14 or 13, I think it was. But all she came in, and these are the symptoms you're going to see with ALL leukemia. It was bone pain, bruising, and anemia, and fatigue. And that's how she came in. Anyway, so leukemia, the definition is an unrestricted proliferation of immature white blood cells in the blood forming tissues of the body. So you've got white blood cells, but they're not normal, okay? They're immature, they don't work. So no white blood cells, guess what? You're going to be up for infections. You will see with leukemia, their white blood counts usually are what, 5 to 10, something like that. You'll see them at 0.1 or 0.01. You're going to see them down to 10 or 100 cells. It is quite impressive, the numbers that you will see there. So what do you see? So my next door neighbor who went in, and the parents had brought her into the ER, and just simply she was having the history was the tiredness, the bruising, and the bone pain and the knee pain. And they did a CBC, and of course they did an X-ray just to be sure, but they found the ALL. Well, just the end of the story. Today, she's a PhD from the University of Miami in psychology. So she came out really well on the other side, but it was a very difficult time. So when you do leukemia and you look at the blood, you're going to see, you do a smear, and what you see is those very immature leukocytes. It's very easily to spot. And then, of course, you're not producing, blood, so your counts are going to be low, requiring bunches of blood transfusions. So we'll be doing bone marrow aspiration to look at those cells very much to see what's going on. Now, chemotherapy is the treatment. So there are 4 phases in it. Induction is literally, we hit them with everything for 4 to 6 weeks. And our goal is to get rid of everything, put them in remission. Now, there's going to be a couple cells left. So they're going to do that consolidation maintenance therapy to make sure it's gone. But induction, our goal is remission, okay? So we'll give a lot of it. Now, they can put it intrathecally, depending on their spinal tap, if the cells are in the spinal column, in the central nervous system, and they can do it there. Now, as I said, one of the things that we can do for leukemia when nothing else is working is to do a stem cell blood transplantation. Now, there's 2 types. Now, there is the patient's own stem blood cells, which is autologous. It's an automatic, yeah, that's is my own. But then there's allogenic, which is a donor. And the best of all of the donor ones is a sibling, a brother, a sister, tend to be the best on them. Yes, we have umbilical cord blood. I mean, that is autologous. It's their own. Hopefully it can work. But as we know, any transplant, what is the big thing with transplant? Is that rejection, right? We call it graft versus host. I saw one older girl at age 20 who was having this graft versus host rejection, and her face was like the skin was peeling off. It was on fire. It was the way she reacted to this transplantation. So it can be anything you might see on it. So again, leukemia is going to be longer term. There's going to be a lot of things going on. Now, the one thing they do is immediately they'll put in a port, which is a central line underneath the skin, somewhere on the upper chest, and it goes into the heart. And nothing's hanging out of the body, okay? And what they do is we teach these parents and these children that if they're going in to get blood work at all, or they're having a fever, go into the emergency room, to put this cream on there, the skin over the area on this port so it numbs. EMLA cream. It's a lidocaine type of cream. Put a little piece of tape or Band-Aid over it, and then they come in, and now that area is numb. And these children will feel touch, but they're not going to feel a lot of pain, which is the best thing because we can access ports really easily. You know, nurses do it in the emergency room. When they come in, we see what's going on. We get the equipment ready. We access it. And now we have a running IV. We've drawn all the labs. And you know, it didn't even hurt that child. So that's the biggest thing. Now, leukemia can hurt. You can have those aches and pains. So make sure that we keep these children comfortable. And as nurses, be careful with those chemotherapy agents. You know, one of the areas in nursing that has a lot of referral bonuses, sign-on bonuses, is children's oncology. They really are in desperate need of nurses to work with children with cancer. And you're going to say, yeah, you don't want to. That's hard. Many of them die. Well, you know, in any area of nursing, you have patients who die. And I listen to it this way. My heart says it is not if they lived or died, okay? Because you can't predict that. You know, there's no rhyme or reason for that. But what did I do for that child and that family when they were alive, you know, and made their life a little bit better? Was it that I sat down and played cards with the kid while the mother ran to the cafeteria so the child wouldn't be alone? You know, those are big things. And those are things that nurses can do, or bring in your computer, you know, into that room and sit with the child while she's watching a movie so she's not alone. All of those things are important. I used to always have ribbons and headbands and things that I would do for the smaller children, you know, so then these children, babies, and this was in the open heart area where you couldn't have any clothes on, but I could have a cute little pink ribbon in the hair, or, you know, maybe pink and red ribbon. And these things made these parents smile. And that's what you need to do. As I said, the prognosis of leukemia is better. It depends on, where was that white count? That first one that we saw, was it that 0.01 or was it 0.1? Makes a big difference. How old was the child? And again, the type of cell, was it ALL or AML? And it's boy and girl. And this karyotype analysis, if you have a rare blood type, you're not going to be able to get the cells you need when you need them. There'll be delays. So if you have an A positive or an O positive, you're good. But what if you have something that's very unusual? So children with cancer, these are different sort of cancers. And we know cancers can be treated by surgery, chemo, and many of those chemos, as I said, are going to be given through that called the venous access or a port, you know, and nurses are trained to do this and they're specialized in it. So signs and symptoms that you will see, a little bit of what I said with my next door neighbor, is pain, fever, ecchymosis, petechiae, bleeding. You know, remember, their blood counts go low. And then, of course, with these bleeding and low blood counts, the lethargy, you know, general malaise, you're going to see those things. And then firm, enlarged lymph nodes. And sometimes you even see those vision changes going on with these children, depending on what's going on. So infection is one of the big things that we're concerned about. There is no white count. There is no immune system. You know, when we look at it, their absolute neutrophil count is lower than 500. And it should be over 1,000, 1,500 or more. Okay, neutrophils fight infection. So if you have a neutropenic child, what is your biggest chore? What's your job? How can you help them? Well, number one, just wash your hands, right? You know, do everything as clean as possible. If you have a runny nose, put a mask on for that child, but always washing your hands is always number one on them, and put them on some sort of, you know, monitor people going in, making sure even the family washing hands, wearing gloves, whatever they need to do. We will be collecting all sorts of specimens that we need. But again, when we're treating children with cancer, and because we're giving these chemotherapies and we're seeing that they're more susceptible to infections and septic shock. And, you know, our goal is for them not to get an infection because of us. Hemorrhages is a big deal. A lot of times your platelet counts go low, and you're hemorrhaging only because your platelet counts are low. Okay, you can, just like with ITP, same thing, platelet counts, what do you see? Bleeding. How do you see bleeding? It could be just that petechial rash or ecchymotic areas. Those things, be aware of it. Looking at their urine, their stool, and their bleeding, their mouth bleeding, etc. These children should not be in any sort of activities that's going to have any sort of, you know, hitting, falling, chances of injury. They shouldn't be doing it. And we know in the beginning, as they're getting that induction therapy, remember I said they're getting hit with all of these chemotherapy agents, their whole immune system is going to be wiped out even more. And you're going to also see their hemoglobin, hematocrits dropping, platelets dropping. So you have to be aware that these children are not going to have a lot of energy, and we need to save that energy for things like sitting and eating and, you know, just being able to take care of themselves. Nausea and vomiting is a big thing. Emetics should be given before therapy. You know, when I started nursing, we couldn't give something for nausea until they vomited. and I always thought, well, why would I do that? Shouldn't we give it so they don't vomit? Well, medicine caught up. So we give it before. They're also using cannabinoids for children. They have those liquid oil things that they've used. They use them for seizures. They use it for antiemetics, and it's been proven it works really well on them. And our goal is, remember, nutrition. They still have to have nutrition. They're still growing, right? So how do we monitor that? Height, weight, okay? Big thing, height and weight. And then monitoring lab values. These children need high protein, high calorie, high fat, high everything, and remember, a lot of them get that mouth sores. So be very careful with, what do we give there? Citrus juices, orange juices may not be what you want to do. And remember, when they talk mucosal mouth, it's mouth to anus, it's the whole GI tract can become very irritated. So very foods that are very soothing, bland, moist, soft foods, soft toothbrushes, mouthwashes, and if the rectal lesions, of course, the sitz baths. Neurologic, sometimes these children, they're not eating well, so they become constipated. What happens when you're constipated? You'll tend to sit on the toilet and you'll just push. What can happen? You can stroke. So be keeping stool softeners, keeping that stool flowing is a thing that needs to be done. These children, if we don't get them up and move and they're just so weak, remember, a foot drop, you think it only happens in adult, it can happen in children too, and quicker than you can imagine. So making sure that we watch those things, and if we need physical therapy for these children. Again, using analgesics as needed so that they can eat what they need to eat, drink what they need to drink. They also can have hematologic cystitis. So again, you're watching for bleeding, as I said. And then, of course, the hair loss, the alopecia. I told you I love little girls. I love putting little ribbons in their hair. And I would have always a couple spools of different colors of ribbons with me. And, I would put one in my hair and put it in my children's hair, and it just didn't make them feel as different. I can't tell you how many fathers and brothers cut their hair off too to be the same as their children. And I think that makes them feel special. They do get a lot of steroids, anti-inflammatory. Remember, steroids can cause Cushing syndrome. And I've got some pictures here to show you, and they can get big and full, with all of those things. So if this child is on steroids, remember that we have to be careful with fluid intake on these children, because they do tend to retention. And remember, their heart is already working hard with a lot of anemia. So we don't want to overstress with some more fluid in there. Many of the procedures we do for oncology children is that they're sedated, but remember, it's not just normal lab works. I went over that in the port and how it could be actually pretty easily. But remember, use those topical anesthetics, numbing things and creams, always give support. And if we're doing something beyond just accessing a port and doing things like a bone marrow or a spinal cord, spinal tap, that as we go deeper inside the skin to make sure that there's lidocaine there too, because it's not going to be one time spinal tap, one time bone marrow, it's going to be multiple. So if it's bad the first time, this child's going to expect it to be horrible the next time. Pain management, remember, it's not just the morphine opioids. Remember, there's Tylenol, there's ibuprofen, that there are things to do to distract children, music, non-nutritive sucker, pacifiers, toys, iPads, TVs, whatever we need to use it for these children. And it does help these children deal with it a lot better. Now, there's two sorts of lymphomas. There's Hodgkin's and there's non-Hodgkin's. This is, the nodes. So lymph nodes. So Hodgkin's lymphoma is these lymph nodes, okay? and it can go to any of the body organs. So what do we see with Hodgkin's disease? Well, this child, you're going to see these big, nodes. Usually you see them above the neck, up in the upper area. And you're going to say, oh, that must hurt. They're painless. They're big, big nodes, but they're painless. That's what says this is Hodgkin's lymphoma. Because usually if you have an infection and they're swollen, you touch them, they're going to hurt. But with Hodgkin's lymphoma, they're big, they're large, but you're not going to be in pain. So painless enlarged nodes is going to be Hodgkin's disease. These children present cough, abdominal pain, not eating, fever, weight loss, and then we go ahead and we do the history physical. We see these big painless nodes and we do a biopsy. What makes it positive Hodgkin's lymphoma is the presence of Sternberg-Reed cells. That is classic Hodgkin's lymphoma. How do we treat them? Well, if it's one area that we're seeing the big nodes, because it's the nodes we're treating. If it's just one, we just treat it radiation, or maybe a couple of them treat it, and then chemotherapy. And children do really well. They do come back from it. But again, it's aggressive therapy. So chemo, radiation, they're going to have all those side effects that I talked about. And with radiation chemo, these children could become infertile as adults. Now, non-Hodgkin's is disseminated. It's everywhere type things. It's very sporadic. It's not big, thick, painless nodes. It's just in the nodes throughout the body. So with this one, usually we'll see metastasis to the bone marrow, and it could present like a leukemia. So how do we confirm this? Again, we got to find some of these nodes. We got to go and we need a piece of it to look at it. And then we do all sorts of x-rays and CAT scans, etc. Treatment's the same, radiation, chemotherapy. And hopefully, we can get it done with that. So brain tumors, brain tumors are the most common solid tumor in children. And it could be malignant or it could be benign. So how do we treat a brain tumor? Well, usually children who present that we figure out it's a brain tumor are children who have headaches, but they get worse as time goes on. So progression of headaches. There also, you're going to see vomiting, and it's not related to eating. It's just vomiting because of the pressure in the head and the headache that they're having. And you'll see it getting worse and worse. And then you might see them get to the point of they're walking, but now they're starting to fall. They're not as alert, and it goes on. But when the headache and the vomiting, those are the two ones that first that we will see. So look for it, see what's going on. And then, with a brain tumor, many of them, they will do surgery to try to remove it. Now, these children will be getting, CAT scans, MRIs, they will be getting, all sorts of IVs, the ports put in, and going through a lot. Again, we really need to remember not only the child, but the family. They're going through a lot to let them know what's going on. Post-operatively, when you have a brain tumor removed, very important. How high can I put the head of the bed? What side can I put that child on the affected side or the non-affected side? And remember, we've moved something from the brain, really monitoring intake and output, because we don't want too much fluid in there. Again, that can increase, the pressure on in the brain. We don't want to do that. Now, there's something called a neuroblastoma, but you don't necessarily see it in the brain first. It is a tumor that's in the belly. Okay, you see that baby there. It's a very, it's very obvious that there's a tumor in that child's belly. But usually it starts that small and then it crosses the midline. Okay, and then we'll start looking, is it in the brain? Usually, by the time we find the tumor in the abdomen, it's already metastasized to the brain. It's very uncommon, very uncommon. And many things go on with these children. You got this big belly, it's going to work, you know, it goes in the brain, you're going to have neurological problems, and that's pushing up against the lungs, they're not going to breathe well, and then it's going to go into neuro issues and thalamus and everything. So we do a lot of chemo radiation on these children, trying to help them, but it is a very difficult diagnosis. Not many of them come through this because, again, it's already metastasized by the time we find out. And then we have osteosarcoma, which is bone tumors. Now, one of the common bone tumors in adolescent boys is a bone tumor on the femur. It will be presented as, in the history, about they fell down, they thought they hurt their leg, they've been limping, but it's getting worse, the pain's getting worse. Now it's swelling and it's red and it's hurting more, so that's why we came in. Then, of course, anemic, depending how far they let it go, they're getting infection, they're losing weight, that's going to the extreme. But if they get in there when it first just starts hurting, you know, they do the x-ray, they see that little hazy cloud on the femur, and that is the diagnosis. So we do a biopsy. We do the biopsy and determine that it is osteosarcoma arising from the femur bone, mostly in males and adolescents. And what we do is we'll do chemotherapy. Now, what they do today is you can't just take the femur out and put another bone in there. We don't have that capability. They used to take the whole leg right up to the hip joint, okay? But today, you know what they're doing? They're taking the lower leg and putting it up into that hip area so that they have something to put their prosthesis on to be able to walk. And if you look at it, the foot's on backwards on the leg. But what that does, it gives an attachment device so that these children can get up and move and can walk. So limb salvage is the preferred. It's what they want to do. But occasionally they do have to do a complete amputation. Wilms tumor. You're going to hear this again when we get to, you know, our GU area, but it is a tumor, so I will mention it. This is boys 3 to 5. It is African American. It is a tumor that arises from the kidney in one side, and it gets bigger and can go to the other side. Now, we usually will diagnose this by child, you know, as something's in the belly. Usually we can feel it. I have a case. Child came from right after the Haitian earthquake a couple of years back. Came in through a religious group. They picked them up off the plane and brought them right to the ER, and I'm the triage nurse. And I said, so what's wrong? And they go, we don't know. We were told, here's the papers, all in French, so, or Creole. I couldn't read it. And brought the kid there. They wanted right to the ER. I went, okay. So I said, all right, I need to do an assessment. I don't even know where to place this child. I don't know why the child's here. I have no clue. So very carefully, I did a head to toe, vital signs, height, weight, listen to the chest. I went to listen to the abdomen, and on the left lower quadrant was a softball size hard mass. And you know, I had never seen a Wilms tumor. Somehow, a little piece of knowledge came out of my head, and I said, this is a Wilms tumor. And why was that important? The thing with Wilms tumor, nursing care, number one, is do not palpate that abdomen. And the reason is this tumor is very fragile, can break off and metastasize very easily. Now, they did an ultrasound, CAT scan. They found out it was a Wilms tumor. And what did they do? Well, of course, the child was admitted. We put him into surgery, chemotherapy surgery, and these children do very well. Did you raise your hand again?
Can you hear me?
Yes.
Might be a little, I just had a patient that was 26. She just passed away on, this was in the peds oncology unit. She passed away because her Wilms tumor had metastasized. They had found it back in 2020 when she was pregnant with her second child, and they couldn't do anything about it. She kept complaining about it. And they were just like, well, it's just probably just chronic UTIs and things like that. Well, eventually she was trying to tell them that, you know, it's something more, and that it was worse pain, and that, you know, that it was kind of radiating to the front of her stomach when she was pregnant. They said even before she said even before she was pregnant that, you know, she would have that pain there and she'd have a lump, but they were just like, it's just pregnancy, and there was nothing that they could do. So then eventually, maybe into her 34th week of pregnancy, that's when they found it. And it was too late. So she only lived a couple of years, and she passed away on Friday. And she, it was a very somber day. Like, I mean, she passed away right when I walked into my shift, and the family was coming back and forth in.
Very hard, very hard.
Mhm.
Very uncommon presentation. As I said, it's usually boys ages 3 to 5. African American is usually what you see them. To see it in a female at that age is one of those fluke events that's, it's just not anything textbook, you know, and the hospital could do a big research on her, you know, to alert maybe another woman pregnant that could, you know, be inflicted with Wilms tumor. Wilms tumor, so this woman was pregnant, and she has this big belly growing, and it's pushing against the tumor. And again, what's going to happen? It's going to break off and metastasize because of all of that movement in there. So let's just say it's that little boy that really upset me. Wow. You have a child who comes in with Wilms tumor. It's diagnosed. Immediately, I put on the chart, do not palpate abdomen. I just knew. They do chemo, they do surgery. Post-op, they monitor, because it's on the kidney, right? Monitor urinary output. And because it's in the abdomen, we also monitor bowel function on these children, because we have to be very concerned that it's still working. Again, these children, ages 3 to 5, they actually do really well. And again, it's a lot about teaching. And it's a lot about that nursing care of not touching it and making sure that we don't do something to make it worse. Now, rhabdomyosarcoma is some sort of soft tissue cancer. It can come from ear, come from a nose, come from an eye, and it is a cancer. And what they have to do is to, you know, remove it. A retinoblastoma. Ever see at nighttime, if you turn on the light in the backyard, if there's an animal, a cat or dog, you see these big white reflective eyes. We call them cat's eyes, okay? That's the whitish glow. When you see a child with a retinoblastoma, you're going to see just like that, like the old camera flash that used to turn their eyes white, or like the cats or dogs or deers or whatever in the yard. You will see that on these children, and that is your clue. It is a retinoblastoma. These children need to have their whole eye removed. It needs to come out, and they can do well as long as we caught them early enough. Now, if you notice, there's that little purple mark that we put, you know, that we're going to be doing radiation therapy. Remember, these cannot be ever wiped or cleaned off, because the radiation people need to know exactly where to put the radiation next time they come. And they do surgical, and then they do surgery. Post-operatively, you know, these children, like this little boy down here, can get a fake eye put in. So they never really know about it. But again, that is in the future. It is so that the child doesn't look, you know, different or have a patch on their eye and be teased for life. Germ cell tumors, you know, you think of testicular cancers. You know, again, another story. 18-year-old kid came in with testicular pain in the triage room, in the ER. And when the other nurse who was in the room with me, you know, pulled his pants down and looked at his testicles, there was a big softball size tumor down, in his testicles. So it was pretty well advanced already. He said he'd had it for a month or so. This child, we sent him for an x-ray, a chest and abdomen x-ray, and it already metastasized everywhere. He died a month later. An 18-year-old boy from testicular pain. Just like with women doing breast, self-exams, boys should be doing testicular exams, because I saw it happen. This kid was an 18-year-old kid. Now, the only good thing was the girlfriend was pregnant with his son. So there was someone to come, but that's really not what that girl wanted or that family wanted. Liver tumors, livers are pretty special. You could take out a lobe and they regrow. A liver transplants are, sometimes you have to take them all out, but children actually do pretty good with livers. So today, our survival rate is 80%. It's probably even more since this book has been written. We know we have so many treatment options out there. They're doing a lot better. We're having so much more research being done. So, our goal with children is this sign in Facebook that says cancer free, and, ringing the bell when you leave the unit the last day to say, I am cancer free, because having a child with cancer is not easy. And being a nurse taking care for these children with cancer is not easy. And again, how did I deal with it for so many years? Because many children died on me. Well, I would cry with the parents. I was affected. It's what I did for them while they were alive. It was putting that boa ribbon or having that little bedside clean and neat for these parents that made it look like their home didn't look like all sloppy and messy, because most parents like everything just so when they have newborn babies, if it was a newborn baby, or I've dressed kids up. I did a bunch of different things and put name signs. Those little things made a huge, huge difference. So just remember that. It's a hard and difficult place to work, but it is one of the most rewarding in the oncology area. So who wants to win today? I think it's like 42 Kahoots. Anybody? Nobody wants to win today. Let's get it done. All right, let's get going. So we'll be out of here probably right at 5 o'clock today. Which statement best describes a neuroblastoma? Remember the picture of that little baby with that big belly? What did I tell you about that big belly and that tumor? It's big, and then it crosses the midline, and then we find it and go, ooh. And neuroblastoma is already in the brain by the time we even go and look. Usually there is already metastasis by the time we know. So it's a difficult diagnosis. What is priority treatment for a newborn of an HIV positive mother? What therapies did I tell you that we do for the newborn, and why? So why are we giving antibiotics to a viral disease? It's not going to work. Remember that. That is something that your NCLEX and your HESIs love to put out there. It's a virus. So antibiotics, no. All we want to do for an HIV mother who had an infant is take the infant and give it every chance in the world to beat the HIV, and that's to improve their immune system, giving those antivirals, because you can get that HIV to disappear. What are symptoms of sickle cell anemia? So sickle cell anemia is some occlusions occur. There's going to be swelling, pain, and we see a bunch of things. If it's continued, you're going to have delay growth. There's no blood going down, no nutrition. You'll see that. And then vision, it could be in the eyes. You can have headaches too. Sickle cell anemia affects which cells? And it is the red blood cells. Good, just making sure. What kind of hemoglobin and hematocrit would someone with sickle cell have and why? So they're going to have a lower hematocrit because these cells die so quickly. Okay, the cells die. That's why I told you when they come in crisis, you're probably going to have to give blood because they're at least a 6 and 18 or 7 and 21. 7 is actually pretty good. What is the treatment for sickle cell anemia? Then I'll ask you, what's the first thing you're going to do for sickle cell anemia? Oops. What we're going to do is we're going to give IV fluids and medications. Remember, the first thing is IV fluids. We want to dilate those vessels and then give the antibiotics if it's an infection and pain medicine. And then blood if we need it. Aplastic anemia includes a depression of which blood cells? Aplastic anemia. So it's your red blood cells, your white blood cells, and your platelets. And what's the treatment? We're going to be giving blood transfusions. Most common type of anemia is iron deficient anemia. Yes, it is. And it's easily correctable, right? Just nutrition or vitamins. What causes pernicious anemia? The intrinsic factor, right? And how do we correct it? Well, we just give B12 to this child or adult, and it will help correct it. Which symptom is the single most common symptom of anemia? There's many things you see, but what's the one that's, this assessment, this history is showing me this is an anemic, something's going on. And it's that fatigue, being tired. Why? You don't have blood cells, you don't have oxygen, and therefore an iron, and you're going to be tired all the time. Good job. When teaching parents about beta thalassemia, the nurse informs that the child is at risk for what? Well, beta thalassemia, it's your Mediterranean type of culture that get it. It's those rectangular cells. And what happens is they die and they burst constantly. And that bursting of cells causes a problem. There's no oxygen, and then that iron is thrown into the blood. So treatment is replacing those cells, blood transfusions, and then because the iron can be toxic, some sort of something to get rid of the iron, whether they're drugs or an apheresis. What lab values will you see with hemophilia? So the PTT, like heparin, is prolonged, but the PT and platelets are normal. And with hemophilia, you're missing a factor, von Willebrand's 8, 9, whichever one. Good. What is thrombocytopenia? Remember P. ITP. When I told you about P, what does that mean? It's all about not enough platelets. Usually this follows the upper respiratory infection and we can treat it, right? We can give some immunoglobulins and we can give some vitamin D. Thrombocytopenia can cause the following symptoms. Well, remember P, that means there's not enough platelets. When you don't have enough platelets, what are you concerned about? What would you see? And you'll see that petechial hemorrhage, that little purplish looking rash, bruising, and then epistaxis is what we usually will see with it. Multi-select. A child with hemophilia has fallen, the knee swollen and painful. Treatment would include what? I mean, if you think of this, hemophiliacs tend to bleed. How do you stop bleeding? Well, you're going to elevate it and you're going to put cold packs. It constricts it, right? It's going to be part of that rice. You're going to rest, ice, contain, and elevate. Very good. Never hot. We don't want to make it bleed more. What is the priority nursing action for suspected blood transfusion reaction? Number 1, turn it off. Thank you. A child is admitted with neutropenia. What nursing action takes priority? Well, what is neutropenia? Well, that means not enough neutrophils. Well, what does that mean? And it's not on contact precaution, isolation. Contact, if they've had something that, could be, communicated to us. No. Neutropenic means they don't have an immune system that can fight. So strict hand washing is absolutely number 1, okay? Doesn't need a precaution, just needs us to be careful with that child. Strict hand washing. Which symptoms would a healthcare professional expect to see with a child with leukemia? My next door neighbor, classic signs. Remember, leukemia, you're going to have your blood counts are going to be very low. Your white count's going to be nothing. And what are you going to see? Bruising, fatigue, bone pain, low hemoglobin hematocrit, low white count. Your child has ALL, has had recent lab results, and the platelet count is 10,000. Nursing action, what are you going to do? What does that mean? That's acute lymphocytic leukemia, ALL. What do platelets do for the body? This is when you put them on bleeding precautions, okay? It has nothing to do with infection. Platelets, if you don't have enough, you're going to bleed. It's ITP, right? You're going to have that petechial rash, nosebleeds, and you're going to have bruising, right? Bleeding precautions, which means no IM injections. Watch them for bleeding. A multi-select. A child is placed on bleeding precautions for ITP. What interventions would the nurse do? And it's everything, okay? No injections because you go through the skin, it can cause bleeding. You're going to look for bleeding for sure. Monitor the CBC. Where are our platelets? Because ITP is platelets. And then they're going to treat them with corticosteroids. That's when they're symptomatic. Child with Wilms tumor, which action by a nursing student causes the faculty member to intervene. What did she do wrong? She went in there and touched the belly, and we don't want to do it. We don't want anything to metastasize to ruin that child's chance for cure. Cancer of the body's blood-forming tissue, including the bone marrow, it's called what? And that is leukemia. All of the following are true concerning a neuroblastoma except. Remember that neuroblastoma is that little belly with that big belly, that little baby. So it is not common, thank God, but it starts in the adrenal glands and the kidneys right there. It also is a lump that crosses midline, and then sometimes you've got this tumor in the brain, so it's squishing out, the eyes, and you're going to see those bruisings there. Thank goodness it's not common. Most common clinical manifestation of a retinoblastoma. And this is that cat's eye reflux, that white looking eye there, and that's how we find them. A goal of surgery for a child with osteosarcoma is what? So what we want to do is to salvage that limb on the bottom, take off the femur area and the cancer, reconnect it so that we have something to attach a prosthesis for. It's easier to get up and move around with it, more comfortable. True or false? Immunizations causes autism. Absolutely not. That happened after the chickenpox vaccine, and yeah, it's not true. A child is complaining about these skin markings for radiation therapy. They should be told what? They put little purple things if they're doing for their retinoblastoma, and they've got these purple marks there and doing radiation. They don't like it. Get it off. And you need to leave them there because we want to give the radiation in the same direction, and that's why those treatments are there. Those little marks are there just to make sure it's the same place every time. A multi-select. Nursing care of a patient with immune thrombocytopenia purpura, ITP. Nursing care. Okay, no IV fluids, okay? ITP has nothing to do with needing to dilate vessels because there's a lack of blood flow. That is nothing. It has to do with bleeding, okay? So IV fluids for sickle cell. It is not for ITP. You don't need to make the volume bigger. There's no problems with blood flow, but no IM injections. You're going to look at that CBC, look at those platelet counts, and then those corticosteroids as we need to treat it. When distraction is used, it helps what? Absolutely everything. The child forgets about what's going on and is more interested in something else. And that's what we want. I think those little bubble things and blowing bubbles is probably one of their favorite things to do and to watch. When assessment question needs asked to a child with possible rheumatic fever, what assessment question? What causes rheumatic fever? This is from last week. Any sore throat because it is an under or not treated strep infection. Good. Signs and symptoms of asthma. Again, another one from last week. I like to come back and hit you with them to make sure you're understanding some of those key concepts. And we know asthma usually starts with coughing, 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 coughing. And it's that shortness of breath and chest tightness, wheezing, and prolonged expiratory phase, right? A multi-select. Absolute contraindication for nasal tracheal suctioning include which of the following? As in, you're not going to put anything in that mouth. And when you talk about that, you talk about those conditions which are already, an inflammation of the airway, and that's epiglottitis and croup. Asthma, it doesn't bother it. An irritable airway, no, the irritable airway conditions are croup, epiglottitis. Iron dextran is given via which route? Now we're talking about iron deficient anemia and we're talking about children. So if we were giving iron dextran, how would we do it? Do you remember from pharmacology? Remember, it's thick, it's viscous, and it also burns the skin. So we've given it deep IM via Z-track. So we pull back the skin, give an injection, pull it out, and I call it a lock and load. So it can't come back out and go all over the skin and stain it. So iron dextran is one of those, we could do. It's one of the treatment plans for iron deficient anemia. Hopefully they'll eat iron or take iron by mouth, but many of them need to have those injections. What cancer may present with painless, firm, and enlarged cervical nodes? Everything here up, big pain, and they don't hurt. They're painless. The key word is painless here, okay? And they're big. Thalassemia major is treated primarily with thalassemia major, rectangular shaped cells that are bursting, right? What are they doing? They're spewing iron into the system. And their cells aren't lasting. So it is blood transfusion is the treatment for thalassemia major or Cooley's anemia. It's the same thing. A multi-select. What are opportunistic infections of HIV? I mentioned two. So yeast is one of them, and then PCP pneumonia. How would you know one or the other? What symptoms? Remember, pneumocystic pneumonia is going to be all respiratory problems. And yeast, whether it's, perineal or in the mouth, You know, we can tell by, you know, the yeast buds that you're seeing there, white. Another multi-select. Treatment of an osteosarcoma includes what? So we would prefer to salvage the limb, but amputation is something they have to do sometimes. And chemo, stem cell transplant does nothing. It has nothing to do with osteosarcoma. You need to shrink it with radiation and chemo and get rid of it. You have to remove it with surgery. Who are the best donors for bone marrow transplants? So actually it's your siblings. They have the best bone marrow that is close to your type, and it usually does very well. You know, some students were saying, well, maybe yourself, but no, the book says your siblings are the best. The most common opportunistic infection for children with HIV, which one's most common? And that's your PCP pneumonia, okay? And it's not a fungus, it would be that Candida tracheitis, but PCP pneumonia, most common. What would you consider to be neutropenia or a low neutrophil count in children? Remember, neutropenia means your defenses against infection are so low, you can't fight infection. Remember, we treat this with strict hand washing. Well, what's that number that's considered low? It's less than 500, okay? Above 500, you're a lot better. It's usually about 1,200 to 2,400, but less than 500, that is scary. And that child, you need to wash your hands and be very careful for infection. A primary characteristic of a brain tumor is what? Remember, this is not an occasional headache. They get worse over time. And their vomiting is not related to anything. It just happens. It's not with food, it's anytime. And the symptoms get worse and worse as the tumor grows, okay? Last question. A child is receiving induction of chemotherapy. What does that mean? What's induction? Remember, there's 4 stages. So induction is the first 4 to 6 weeks of chemotherapy. They hit with everything, multiple different types, 2, 3 different sorts of chemotherapy. So we're going to be in remission when we're done. Then the other 3 steps are just those couple cells that are left, getting rid of them, and then it goes just on to keep it from coming back. But induction is initial, and it's the goal of remission, getting rid of it and wiping it out. Number 3, Jasmine, you've been fighting all games. Stay up there. Ulysses, yep. And number 1, Kenisha. Kenisha have been fighting too. Number 4, Lauren and Brianna. What I'd like you to do is sign your attestation so that they're done, so you don't forget. Anybody have questions for me? Anything I can do for anybody?
Miss Bogart, I have
Yes,
a
ma'am.
question.
Yes.
So, Memorial Day is next Monday. So how are we gonna do our exam?
Isn't it in 2 Mondays?
I thought it would, I
Yeah.
don't know if it's, yeah, okay. I'm
We're
ahead of
okay.
myself.
We're okay. And next week, we're just going to have you either listen to a recording or you can attend another class, whether
So we don't have
mine or
exam.
another professor. Excuse me?
We don't have exam next Monday.
No, 2 weeks, week 7.
Oh, okay.
Oh, wait a second. Next Monday, we have an exam. In 2 weeks is Memorial Day. So it's not during an
Oh.
exam. You had me confused for a second.
Okay.
Yeah. Remember, there are the reviews this week, and mine is on Friday at 2. And I will be posting everything. And you already have your study guide PowerPoint, okay? If you need
Okay.
anything, let me know. Let me know what your projects are too, okay? You guys take care.
Bye. Take care, Professor.
You too.